This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending, and today we're diving into the technical nuances of spinal infections.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Orthopaedic Surgery, published in 2026, titled The Application of Selective Intersegmental Laminectomy with Irrigation Technology in the Treatment of Spinal Epidural Abscess. It comes from the Department of Orthopedics at the Affiliated Hospital of Qingdao University.
This is a timely topic. Spinal epidural abscess, or SEA, remains a life-threatening emergency. We've all seen these cases where a patient presents with that classic triad: fever, spinal pain, and neurological deficits, though as the paper reminds us, that triad only shows up in about 30 to 50% of patients.
Exactly. And the pathophysiology is quite aggressive. We're talking about suppurative or inflammatory exudate accumulating in the epidural space, which causes spinal cord compression. The paper highlights that because the abscess is in a liquid phase, it has a certain fluidity that allows it to spread across multiple segments of the spinal canal once it forms.
Right, and that's the surgical dilemma. Historically, the gold standard has been laminectomy for decompression and irrigation, but if the abscess spans 5 or 6 levels, a continuous multisegmental laminectomy, what the authors call CMLD, is incredibly invasive. You're looking at massive tissue trauma, potential spinal instability, and often the need for instrumented fusion with pedicle screws.
And that's where this SILI technique comes in: selective intersegmental laminectomy with irrigation. The authors wanted to see if they could achieve the same debridement through a skip-level approach combined with hydrodynamic bidirectional irrigation.
Let's break down the SILI technique as described in the paper. Alara, walk us through the mechanics of how they actually perform this.
It's quite strategic. Instead of taking down the entire posterior arch over the length of the abscess, they perform selective laminectomies at both ends of the affected segment. This creates 2 apertures at the extremities of the abscess collection.
And why is the placement of these apertures so critical according to the study?
It's about pressure equilibrium. By having openings at both ends, they can insert a fine drainage catheter into the epidural canal. The dual openings facilitate an unobstructed fluid flow. This hydrodynamic bidirectional irrigation allows them to wash out the abscess thoroughly without the high pressure that might otherwise disseminate the infection further into the spinal canal.
It's essentially using the fluid properties of the abscess against itself. If it can spread easily, it can be flushed out easily, provided you have the right entry and exit points for the irrigation. The goal here is to preserve spinal stability and mobility by keeping those middle laminae intact.
Precisely. Now, looking at the study design, they retrospectively reviewed patients from March 2020 to July 2024. These were patients with SEA affecting 3 or more segments who already had neurological deficits. They compared the SILI group to a control group that underwent the conventional continuous laminectomy, or CMLD.
And the results were quite compelling. Let's start with the inflammatory markers. In the SILI group, the white blood cell count dropped from an average of 13.44 down to 8.56. C-reactive protein, or CRP, went from 80.11 milligrams per liter down to about 21.18.
And the erythrocyte sedimentation rate, or ESR, saw a similar massive decline, from over 93 down to 29.74. All of these were statistically significant, with p-values less than 0.001. So from a systemic infection standpoint, the skip-level irrigation was clearly effective at source control.
But for those of us in the OR, the radiographic and functional outcomes are what really matter. The authors used MRI measurements to quantify the axial area of the abscess and the volume.
Yes, they found a significant reduction in abscess volume and a corresponding expansion of the dural sac area. This confirms that even without removing the bone over the middle segments, the irrigation was able to clear the space and relieve the mechanical compression on the cord or cauda equina.
What I found most interesting was the functional recovery. They used the JOA scores and VAS for pain. Both groups improved, which you'd expect after surgery, but the SILI group actually outperformed the conventional group at the 6-month and 12-month marks.
That's right. If we look at the modified McNabb criteria, the SILI group had an excellent rate that jumped from 55.56% at 3 months to a staggering 91.67% at 12 months postoperatively. This was significantly better than the CMLD group at the 1-year mark.
Why do you think that is? If both surgeries remove the abscess, why would the SILI patients do better long-term?
The paper suggests it's the preservation of the spinal anatomy. By avoiding the extensive spinal tissue trauma of a continuous laminectomy, you're reducing postoperative pain and maintaining more of the natural biomechanics. Less bone removal means less chance of late-onset instability or the need for secondary fusion.
It's the minimally invasive philosophy applied to a traditionally maximalist disease. One thing that stood out to me in the paper was the focus on the pathogens. They mentioned Staphylococcus aureus as the primary culprit, 60 to 80% of cases, but also noted that we're seeing more atypical pathogens now, like Mycobacterium tuberculosis and fungi.
True. And they emphasize that the subacute manifestations are the ones that catch people off guard, persistent back pain or unexplained paraparesis without the high fever. They argue that the pathogen virulence heterogeneity makes early MRI and tailored surgical strategies like SILI even more important.
Let's talk about the irrigation itself for a second. The authors mention hydrodynamic bidirectional flow. In a resident's or a student's mind, they might just think of rinsing out the wound, but this sounds more sophisticated.
It is. By using the fine drainage catheter inserted through one of the selective laminectomy sites, they can direct the saline specifically through the epidural space. Because there's a sink at the other end, the second laminectomy site, they create a flow circuit. This ensures that the debridement is sufficient, even in areas where the surgeon doesn't have a direct line of sight.
And no major complications were reported in this series. That's a big deal. When you're doing blind irrigation in the spinal canal, there's always a worry about increasing pressure and causing further cord injury. But the authors highlight that the apertures at both extremities are specifically engineered to maintain pressure equilibrium.
It seems the key takeaway for our listeners is that if you have a multi-segment SEA, you don't necessarily have to unzip the entire spine. Strategic selection of laminectomy sites can achieve effective evacuation.
It's a shift in mindset. We often think more bone removed equals better decompression, but this study argues that strategic bone removal plus technology-assisted irrigation might actually lead to better functional recovery and an excellent rate of patient satisfaction.
Before we wrap up, I should mention that the authors also emphasize the risk factors. Diabetes mellitus remains a major risk factor for these immunocompromised states that lead to SEA. So while the surgical technique is vital, the systemic management of these patients is still the foundation.
Absolutely. A 10-minute deep dive doesn't do justice to the whole paper, but the core message is clear. SILI technology allows for effective debridement while preserving spinal anatomy and mobility. It's an elegant solution to a very messy clinical problem.
And for the residents listening, the data shows that the SILI technique specifically improved JOA scores more effectively than CMLD at the 12-month follow-up time. That long-term recovery is what we're all aiming for.
Well, that's our time for today. Thank you, Dr. Ilara, for breaking down the data from the Qingdao University study.
My pleasure, Dr. Ilara.
Join us next time on the Neurosurgery Hub podcast as we continue to explore the cutting edge of spinal surgery. Until then, keep learning and keep operating.